Hi, my name is Dr.Jean Karl. I'm a family doctor and I'm an occupational health doctor, a specialist in occupational medicine. I am not a virologist, I'm not an immunologist, but part of my studies, I have basically studied how to search for and critically analyze the medical literature. And recently I have been quite interested in looking at the medical literature around COVID-19 and SARS-CoV-2. Okay, I think most people know that SARS-CoV-2 is a novel virus which has started to infect people in the recent, just over 1.5 years. And it's created a lot of concern. SARS-CoV-2 causes COVID-19, an illness mainly of the respiratory system, but it also affects other organs, and which has, in certain age groups, quite a high mortality. SARS-CoV-2 is a seasonal virus, and that's why we have seen you see cases all the year round, but if you look at the actual mortality, you can see that the mortality of COVID-19 tends to be much higher in winter than in other months, and this is because of viral triggering. And basically, at certain times of the year, the combination of humidity, temperature, and UV light levels, have an effect on the virulence of the virus, and in winter it becomes more virulent and it causes more disease and more disability and death. However, there is good news in the sense that COVID-19 tends to be less lethal than influenza in those of the age of 45 years or younger. However, over the age of 45, the mortality, from younger to the older ages, the mortality more or less doubles every 6 to 7 years of age. So basically over 45 it then starts to increase, and as you hit the age of 85, the mortality from COVID-19 is about 15%, which is quite high, and is actually, I think, higher than influenza itself, although we're not entirely certain. But it seems to be higher than influenza in older people. Under the age of 70 years, the average infection fatality rate, so if you get COVID, the chance of dying is about 5 per 10,000 people. There are a number of effective vaccines against COVID-19. The efficacy against infection for the Pfizer and Moderna vaccines is about 90% or above. This protection against infection, unfortunately, tends to fall over time. Over a few months, the protective effect tends to be less, especially with certain mutations. Other vaccines like AstraZeneca and Johnson & Johnson have less efficacy and probably more side effects per dose, more serious adverse events per dose. So I would recommend not selecting those as the primary vaccination treatment. With the vaccines, in people who are older, they reduce the chance of getting the infection. They reduce the chance of getting into hospital and ICU and deaths. And the chance of dying if you over 65, 70 years of age is high enough that you should not really be too concerned about side effects or serious adverse events. However, the serious adverse event rate of these vaccines may be in the region of 1 per 5 or 10,000 people vaccinated. And some of these serious adverse events, including myocarditis, pericarditis, neurological complications, hemorrhage or thrombosis, which are linked to the vaccine, even a low death rate, possibly the deaths from the vaccine are about 1 to 10 per million. We don't exactly know. So there are concerns about the vaccine, and this has caused many national authorities and also the World Health Organization not to recommend the vaccination, for example, of healthy children and young adults, because it's possible that the side effects, the serious adverse events of the vaccine may be more frequent than those you get from actual COVID infection. And therefore, at this time, WHO is recommending the vaccination of children and young adults who are at increased risk from COVID-19, but not healthy children and young adults. And many national authorities have recommended against the routine vaccination of healthy children, although some countries have changed that policy, mainly due to political pressures. So if you're young and healthy, you probably do not benefit from the vaccine, according to the evidence, which is not entirely perfectly clear, but that is the indication. But certainly, if you're older, vaccination is very important to protect you from the infection, maybe for a few months, but maybe for a longer period protects you against hospitalization, ITU admission, and death. the FDA has authorized booster doses for those over 65 years of age, but not those younger than 65, especially those who don't have other vulnerabilities. If you're older than 65, it's probably worth taking. In fact, I think I would strongly recommend taking a booster dose, because the protection against infection seems to fall with time. Because SARS-CoV-2 is a seasonal virus, it's more important to be protected in the winter months when the infection is likely to be more virulent. And so one may time the choice, to be vaccinated, time the vaccination itself or the booster to have timely protection against the virus in the winter months, where it is expected to be more prevalent and to have more cases, and possibly there may be strain on the healthcare system. Natural immunity is more protective than vaccination against reinfection. Whilst the efficacy of the vaccines against reinfection is probably about 90% or more, with natural immunity, according to Public Health England, the studies they have done, the chance of being reinfected once you've had COVID-19 is far less than 1%. It may be anything in the region from 0.7%, but most likely is closer to 0.03%. So the protective effect of natural immunity is superior to 99.9% according to observational data. The protective effect of natural immunity is probably lasts much, much longer than vaccine protection. The antibody levels tend to fall, but your B cell, T cell, plasma cell, memory cell, and IgA immunity and T killer cell immunity may last for, in combination, the immune protection from reinfection may be 5 years or more. But for the vaccine, you probably need a booster after a few months. According to observational data also from Israel, there's a number of cases at the moment. Proportionately, the least represented in those being reinfected are those who had COVID-19 infection in the past. Let's not forget that the PCR test is not very reliable. If you do the PCR test on someone who doesn't have symptoms, the test may be positive even if you are not carrying live virus. It's more likely to predict in real infection if the PCR test is positive in less than 24 cycles in the 5 days after the first emergence of symptoms of COVID-19. Talking about infectivity, it seems that whether you're vaccinated or not, you carry the same amount of virus in your nose if you are exposed. So whether you're vaccinated or not, you can infect someone else with SARS-CoV-2 and cause COVID-19. The people who do not tend to transmit the virus are those who have natural immunity, because the natural immunity, the virus enters through your nose, it's not injected into your shoulder. With a vaccine, you get it as a respiratory infection. You develop IgA immunity, which protects you. It's a neutralizing antibody in your nasal passages, and so you don't carry the virus and you don't spread it if you have natural immunity. And the natural immunity, let's not forget, lasts probably a number of years. If we talk about measures that have been taken in response to the pandemic, originally the WHO in 2019 had done a study on pandemics and epidemics of influenza and made a number of recommendations. These included never closing borders, never doing exit and entry screening, never quarantining people who had just a simple contact but were not infectious. So lockdowns were not recommended unless you had extreme situations. This again has been confirmed with more than 20 studies have shown that lockdowns do not add anything over voluntary social distancing. People know that they should not mix in large groups, especially during a pandemic, and they tend to distance themselves from others voluntarily. If you can distance more than 1 meter away from another person, you are reducing the chance of being infected drastically. So 1 meter social distance is all that's needed, and that should be voluntary. Any additional measures, including enforced business closures, enforced border closures or travel restrictions, enforced mask wearing, enforced school closures, have not been shown to reduce COVID mortality or COVID cases over and above social distancing in a large number of high-quality, robust studies. Lockdowns don't work, and they have enormous costs, both financial and also psychosocial. Masks only possibly reduce the transmission of COVID-19 if you can't respect the social distancing. The evidence on masks is very poor. Some studies have shown effects in hospital settings or in controlled settings. And basically, we know that masks have impacts on impeding respiration, impeding normal breathing, and may also cover normal facial expressions. As such, masking is something which should not be enforced. The WHO is actually at this stage saying, in the case of children, they should only wear masks if social distancing cannot be respected. And any enforcement of any masking in children it should take in consideration all the possible harms and psychosocial effects. As such, WHO is not recommending the routine masking if social distancing can be respected. Thank you very much for your attention.